Hi, this is Mrs. White, and today we will be talking about the endocrine system, including the structures and assessment. The endocrine system is responsible for helping to maintain homeostasis, control metabolism, growth and development, sexual function, sleep-wake cycles, reproduction, and mood. It does this through substances called hormones. Hormones are chemical messengers that coordinate different functions in the body. We have discovered over 50 hormones in the body. The endocrine hormones exert their effect on target tissues using a lock and key type of mechanism. So for here you have some fill in the blanks where you can put down your endocrine system functions, which we've already gone over. Now, some hormones communicate between two glands, in which the release of the hormone from one gland stimulates or inhibits another gland. An example of this is the communication between the pituitary and the thyroid. The pituitary stimulates the thyroid to release the thyroid hormone, which then exerts its influence on various tissues in the body. Another type of communication is between a gland and a target organ. For example, when the pancreas releases insulin, which acts on the muscles and livers to produce glucose. Hormones can also stimulate or inhibit the endocrine system using positive and negative feedback. So here we'll go to the next slide where we look at the different types of glands, endocrine versus exocrine, and honestly, why should we care? There are definite differences between the two. Exocrine usually has to deal with secretions, especially to the epithelial surfaces through ducts and passages, okay? So they are considered a ducted system. Endocrine, on the other hand, makes the hormones, releases the hormones directly into the bloodstream. They are ductless. Exocrine doesn't make hormones, it makes secretions, so that's a little difference as well. So between the two, endocrine, because they don't have ducts, it's not that they're stored necessarily anywhere. A few differences here and there, but as soon as they're produced, they're released. And so I have a picture of the endocrine system, which we're talking about the glands, right? The pancreas, adrenal glands, thyroid. The pancreas, you'll see, does have endocrine and exocrine function, so it's an outlier. But in general, the exocrine, when we're talking about that, we're talking about things like tears, saliva, sweat from the sebaceous glands, enzymes from the stomach. So hormonal regulation really does basically, it's positive and negative feedback. You need to know the difference between positive and negative feedback. Negative feedback works like a thermostat. These loops occur when a change in one direction produces a change in another. For example, a rise in a substance's concentration produces feedback, which causes the substance's content to reduce. An example of this would be calcium in the blood and the parathyroid hormones. Negative feedback loops are mechanisms that seem to be naturally more stable. When combined with the many stimuli that can affect variables, negative feedback loops usually result in the values sort of remaining around pretty close to a set point. Now, positive feedback is like a furnace that turns on and doesn't turn off unless there is a specific mechanism in place to stop it. One of the most common examples of this would be the birth of a baby. The cervix stretching causes a release of oxytocin. This rises in the body and is left unchecked until the stimulus, which is the stretching of the cervix, is removed. So that's the difference between negative and positive. Most hormonal secretion works on negative feedback. Again, like a thermostat, we have a point, we want it up there. As soon as we reach that point, it turns off. Hormones can also be released by nervous system activity, things like pain, fear, sexual excitement, other stressors. And further, some hormones are regulated by the circadian rhythm. So those are our sleep-wake cycles, and also the diurnal cycles. I misspoke. Diurnal is the same as circadian. But also we have things with reproduction that are often regulated by that 28-day cycle. So what happens? What can go wrong? So dysfunction. So dysfunction really is the imbalance of the production of the hormone or the body's ability to actually use the hormone. This can be primary or secondary. Primary is a problem with the gland itself, that it is over-secreting or under-secreting. And you can read here, but I'll just state it out loud, that it can be due to things like infections, damage, autoimmune. Oftentimes when we're having too much secretion, the cause is usually hyperplasia and overgrowth of the cells for some reason. And secondary is factors outside of the gland itself. Certain medications that we take, having trauma to the area, of having hormone therapy. So the gland isn't the issue. The problem lies outside of the gland, but it affects it. So now that we've got an overview of the endocrine system, we're going to specifically talk about some of the glands. The hypothalamus is found up in the brain. It's found under the thalamus, which makes sense to be called the hypothalamus, and it is directly connected to the anterior and the posterior pituitary. It strongly influences pituitary gland function. In fact, it's located pretty much right next to or on top of the pituitary gland. The hypothalamus secretes antidiuretic hormone, ADH, and oxytocin directly to the posterior pituitary. And it further directs the anterior pituitary. So as we know, the pituitary gland is known as the master gland. I think that's a little bit of a misnomer because of the role of the hypothalamus, but it's known that way because of all of the hormones that directly act on the rest of the body. Things like adrenocorticotropic hormone, which stimulates the adrenal cortex to release aldosterone and cortisol. Growth hormone, which has a role in anabolic metabolism, cartilage growth, catabolism of fat, blood glucose, other insulin effects. It enhances T3 and T4. Luteinizing hormone, which stimulates ovulation and formation of a corpus luteum, as well as production of the testicular and ovarian hormones. Follicle stimulating hormone, which stimulates the growth of ovarian follicles containing eggs and sperm production. Prolactin, which stimulates the production of milk in the breast. And TSH, which stimulates thyroid to release T3 and T4. I have here a picture, this is directly from the textbook, about the different hormones that are released from the anterior pituitary and their effects. So you can see on the left-hand side is all the anterior pituitary, and the posterior you have antidiuretic hormone, or ADH, and oxytocin. But remember, they're made in the hypothalamus and sent down to the posterior pituitary and released from there. So it's an interesting way that it works, but expected to know that. And if we recall the functions of antidiuretic hormone, it's to regulate fluid volume, and it's a very potent vasoconstrictor. Oxytocin, often we have it just targeting the mammary glands and the uterus for smooth muscle. However, in males, oxytocin does have a role in sperm ejaculation. So let's move on down to the thyroid glands. So the thyroid is basically located in the anterior neck, And the major function of the thyroid gland is going to be based on 3 different hormones. So they are the thyroxine, which is T4, and 90% of the hormone made by the thyroid is thyroxine, or T4. Triiodithyronone, or T3, is only about 20% of the circulating hormone, but it's more potent and has a greater metabolic effect than T4. And then calcitonin. Calcitonin lowers serum calcium levels by a few different ways. Basically, it inhibits the transfer of calcium from the bone to the blood. It increases calcium storage in the bone, and it increases renal excretion of calcium and phosphorus. So calcitonin, very important. Anybody who took lectures with me before, when we talked about hypercalcemia, one of the treatments was calcitonin because it pushed the calcium back into the bone. Also with thyroid function, it's very important to know that we need iodine to synthesize thyroid hormones. Without iodine, we cannot make the hormone. This is why many of our foods, and especially salt, have iodine added. And I have a picture here that shows you some of the foods that are high content iodine foods. So a lot of seafood, some dairy, some nuts. NCLEX wants you to know these things, so take a peek at the iodine diets. The parathyroid gland is actually part of the thyroid. There are little spots that sit on the thyroid. There can be 2 to 6 parathyroid glands, and basically parathyroid hormone acts on the renal tubules to increase the excretion of phosphorus in the urine and the reabsorption of calcium. It stimulates bone breakdown and stimulates calcium absorption in the GI tract. Additionally, it stimulates conversion of vitamin D to its most active form. So as a reminder, sometimes you might hear parathyroid hormone called parathormone. When we look at the patient with too much parathyroid hormone, what are some things you might think of to look for? Look for bone damage, hypercalcemia, renal damage. Most of our problems with parathyroid dysfunction are due to cancers and tumors, and secondary causes. Chronic renal failure is very common. So if we have too little parathyroid hormone, what might you see? You might see hypocalcemia with elevated phosphate levels. Again, that's because the parathyroid works to balance our calcium and phosphate. So as we continue our walk on down the body, we're going to take a stop here to the adrenal glands. So the adrenal glands are located at the top of each kidney. So you have a right and a left adrenal gland. And there are various parts of the gland that you are responsible to know. So the adrenal medulla is the inner part of the adrenal gland, and it secretes the catecholamines, which are involved in the sympathetic nervous system. So those catecholamines are epinephrine, norepinephrine, and dopamine. Again, they are part of the sympathetic nervous system, and that's the fight or flight response, which we learned about under shock. The adrenal cortex is the outer part of the adrenal gland. And just so you're aware that cholesterol is needed for steroid production here. And this secretes the glucocorticoids, which inhibit the inflammatory response. So, and they have an effect on glucose metabolism. So cortisol is absolutely necessary for life. It's a diurnal secretion, so it has a sleep-wake cycle secretion, and it regulates glucose by stimulating glucose production in the liver, and it decreases the inflammatory response. Mineral corticoids are essential for maintaining fluid and electrolyte balance. And the one that we think about here is aldosterone. So aldosterone regulates extracellular fluid volume, and it promotes renal absorption of sodium and excretion of potassium. And the next one is the adrenal androgens. So the adrenal androgens are converted to sex hormones in the periphery. So they're a major source of estrogen in postmenopausal women and a source of testosterone in men. I have here just a picture of the stress response system. So what happens and the different hormones that are involved. So go ahead and take a peek at that. It's just a cute little cartoon. So we're going to continue our little walk down. Now we're heading to the pancreas. All right, so the pancreas is located posterior to the stomach. It is both an exocrine and endocrine gland. So the islets of Langerhans have 4 types of hormone secreting cells. The ones that we mostly concern ourselves with are the alpha and beta cells. Glucagon is made by the pancreatic alpha cells, and that increases blood glucose levels by stimulating glycogenolysis, glyconeogenesis, or ketogenesis. There is a rapid release in response to low blood glucose levels, protein ingestion, and exercise. Insulin is made by the pancreatic beta cells, which regulates metabolism and storage of carbs, fats, and proteins. It decreases blood glucose levels by facilitating transport of glucose into the cells. As a reminder, increased blood glucose levels are the actual stimulus for insulin synthesis and secretion. Some things like low blood glucose levels, glucagon, somatostatin, hypokalemia, catecholamines, they usually inhibit insulin being released, which makes a lot of sense because in those cases we would need to have more circulating glucose. So if we are inhibiting insulin secretion, that would be ideal. So as we go now into the more assessment part of it, let's take a moment to look at the effect of aging on the endocrine system. So gerontologic considerations. Overall, we have decreased production and secretion. In some instances, like thyroid hormone, even though there's decreased secretion, it's also not broken down as fast. So we end up with a pretty much no change in the net. We have changes in circadian rhythm. Assessment is absolutely much more difficult in the elderly, and this is because of so many conditions that they may have and use of medications. So those things change the body's usual response to the hormone secretions. So I have here for you just some hormones that change with aging. Okay, so pause and take a look at that. Not necessarily have to know, but good to know, especially about the thyroid. Okay, so assessment of the endocrine system. Sometimes this is one of the hardest things that we do because basically for most problems that a person is presenting with, it's a rather slow, insidious onset. Person has a lot of vague symptoms. We tend to misinterpret them. Or on the other side, they may present with acute, life-altering or life-threatening conditions that we would need to be able to recognize immediately and interact and make sure that we do the right things so that the person has the best chance of survival. So we have to look at what are some things that we'll see, right? So subjective. So things that we need to worry about in the subjective history would be things like their past health history, so their background. Again, many vague symptoms that they'll complain of. The most common are fatigue, weakness, menstrual irregularities, and weight changes. We want to make sure we have a good medication history, including not only prescription, but over-the-counter and herbal and supplements. Look at a history or present use of hormone replacements, including steroids, thyroid medications. Any history of radiation to the head or neck. Their family history. Is their family tree full of diabetes, thyroid, endocrine disorders, cancers? A lot of these things have a familial tendency, especially the endocrine cancers. Their nutrition and weight. We want to know, do they have an increased or decreased weight? And it's important to note whether they're eating the same, eating more, eating less. Do they have nausea, vomiting, diarrhea? Do they have increased or decreased thirst? Increased or decreased urination? Constipation or diarrhea? Any changes in their activity levels and their energy and fatigue? Do they feel rested after they wake up from sleep? That's called restorative sleep. Any problems either falling asleep, staying asleep, or multiple wakings during the night? Cognition and mood, things like memory deficits. How do they feel their cognition is? Balance disorders, mood like depression and anxiety. Any changes that they might complain of in their vision? Sexuality and reproductive, we want to look at their menstruation. We want to make sure that we ask those questions. It's okay to ask a man how he's doing sexually. It's okay to ask a woman how she's doing sexually. We want to know, are there any decreased libido, infertility, abnormal hair distribution, right? So hair growing where it shouldn't be or hair thinning where it should be. And then we move over to the objective side, where this is where these are things that we can observe, right? A person may state that they feel like they're losing weight, but until we weigh them, we don't have an objective measurement. So vital signs, height and weight, their alertness, excessive growth of small bones, soft tissues, looking at their BMI, looking at their skin for any changes in skin. Is it rough? Is it smooth? Is it thin? Is it thick? Their head, looking for, again, growths, abnormalities, enlargement of the neck, any changes in the thorax, abdomen, extremities, genitalia. Do they have a rounded center and very thin legs? The genitalia of normal size and shape for their stated age. And we have to move on down to some of the diagnostic studies that we can do. So we can check the blood for a lot of things. We usually check BMP and CMP, hormone levels. We can check phosphate and calcium levels for parathormone. And additionally, some of the other hormones, they affect so many things. So if we have a baseline CBC BMP, it's pretty important. We can check hormone levels directly. TSH is one of the ones we check all the time. It's the most sensitive and accurate thyroid test. And we should reflex that test to T3, T4, and total T3 if there's any abnormalities. So what does that mean, reflex? It means that if you have an abnormal TSH, that it will automatically check those values for you. Urine studies, we often need a 24-hour urine sample. So as a nurse, you are responsible to know how to collect a 24-hour urine sample and also teach the patient how to collect a 24-hour urine sample. We do a lot of radiology testing, including CTs, MRIs. And remember, for CT and MRI, we're always looking for the iodine and shellfish allergy. We might do radioactive iodine uptakes. And that's the case where I have this picture here for you. It shows this abnormal thyroid function by having the person ingest the radioactive iodine and see how much of it goes into the thyroid. So the problem with this is that it can have an effect on the kidneys as well. So we want to make sure we're hydrating after. We want to flush this radioactive iodine out of the system. The person is not radioactive. There's no concern there, but we just want to hydrate them. So when you come to class, come prepared to discuss how do we collect a 24-hour urine. It's a very common thing we have to do, and important that you know. Okay, so a couple of questions, and I'll release you from this one. So this is testing your knowledge, and you can pause this at any time. Patient has a serum calcium total level of 13.4 milligrams per deciliter. Which order would the nurse suspect? Your choices are type 2 diabetes, hyperphosphatemia, hyperparathyroidism, or magnesium deficiency. Again, you can pause at any time. Pause, figure it out, but I'm going to go to the next. And the answer is hyperparathyroidism. And here's the rationale. 13.4 is too high, so that's hypercalcemia. And serum calcium levels are increased in hyperparathyroidism. Right. Next question. Patient with thyroid nodules is to undergo a thyroid scan with oral radioactive isotopes. Which instructions, if given by the nurse, are appropriate? The first is the test cannot be completed if you have an allergy to iodine or shellfish. It's important to drink at least 2 or 3 liters of liquids for the next 1 to 2 days. Isolation is required for 24 hours until the radioactive substance is gone from your body. Or sedation is necessary to ensure that you do not move while the scanner moves over your neck. Okay. The important takeaway here is that they need to drink 2 to 3 liters of liquids for the next 1 to 2 days. And this is because we need to flush that radioactive substance out of the body. For this one, the iodine that we're giving to patients is very low. So it's the amount of iodine in the preparation is very, very small. Unlike some of the other tests, like when we do CTs and CT scans with contrast, those have higher amounts, so more likely to react if they were. And even then, it's still very rare. It's just something that NCLEX likes to test you on. All right, you guys, so this is the overview of the endocrine system. You have some work to do if you don't understand what the glands are and what they do and how they are controlled. Thank you very much. Have a good day.